Well, hello everyone, and welcome to our Winship webinar, updates in the management of bladder cancer. We are excited to have today with us Winship urologist, Dr. Shreyas Joshi and Dr. Brendan Browne, who today will discuss recent advances in the diagnosis and management of patients with localized and advanced bladder of the cancer, cancer of the bladder. Dr. Joshi serves as the director of the Bladder Cancer Program here at Winship Cancer Institute. A board-certified urologist, Dr. Joshi specializes in the surgical treatment of urologic cancers, primarily involving the bladder, kidney, and prostate, with a particular specialization in open laparoscopic and robotic approaches. Dr. Browne is an assistant professor here in the Department of Urology at Emory University School of Medicine and is also a board-certified urologist. Dr. Browne's primary clinical focus is in general urology and endourology, including treatment of urologic cancers. We will start today with Dr. Browne, and we'll let him take it away from here.
Hello, my name is Brendan Browne. I'm one of the urologists here at Emory Urology, and I practice largely at the Midtown location. And so I was very happy to use this slide that shows the building that's currently under construction right next door to our office. It looks almost like this, but there is still some work moving along, and I'm really excited about the opportunities and resources that'll be available for Winship at Midtown in the near future. So today we're here to talk about bladder cancer, and we'll go ahead and jump right in. Disclosures wise, I do some work in medical device development on a variety of urologic topics, but we're not going to address any of the topics that these cover in today's conversation. Bladder cancer is one of the more common diagnosed cancers in the United States, coming in 6th behind prostate cancer, which is also in our world, and breast and others. It accounts for about 4% of the new diagnoses per year. And fortunately, there does seem to be a slight decrease over the past few years in new cases, but it's still a large burden on the healthcare system and the patients who are unfortunate to get this disease. Fortunately, though, majority of those patients are diagnosed with non-muscle invasive bladder cancer, which certainly has a lot more options for treatment and a better prognosis. The majority of patients who are diagnosed with this are later in their life, median age of 70s, and certainly a male preponderance that has been there for many, many years. While there are treatment options, the mortality associated with this cancer still is rather significant and has been relatively steady over the past several decades, despite advancements in other types of treatments. The majority of these patients come into the urology clinic with new complaints of blood in their urine, urinary symptoms, burning with urination, pelvic pain, or they had imaging for some other incident, and this was an incidental finding, whether it be a bladder mass or hydronephrosis on their scan. The tumors are usually visually diagnosed initially in the clinic on a flexible cystoscopy, but then we quickly move to the operating room to get both a tissue diagnosis as well as a staging information with a TURBT. The goal of these resections is to resect everything visible, every visible tumor, as well as sample some of the muscle. As you all likely well know, the invasion into the muscle really is a big delineating and stratifying factor for both prognosis as well as treatment options moving forward. Once non-muscle invasive bladder cancer has been confirmed, these patients are further stratified into different risk categories. There are a few different algorithms for risk stratification, one from the American Urologic Association, one from the European group, and they do follow similar concepts, with the smaller low-grade patients being the low risk, and then the T1 carcinoma in situ or variant histologies being high risk. And then there's a intermediate category that has some slight differences. When it comes to low risk non-muscle invasive bladder cancer, the primary means of treatment is the resection itself. These already have a lower risk of recurrence, but there is still been shown to be benefit of instilling chemotherapy into the bladder shortly after TURBT. BCG, which we'll talk about in a little bit, doesn't really have much benefit or utilization in this cohort because the risk of recurrence is already relatively low. And then we continue to surveil these patients for about 5 years, and then, as indicated, based on new symptoms, if they show any evidence of recurrence along the way, a repeat resection is indicated, and they either return to their low risk category if they're found to have any higher risk features, then they move into that category for treatment. In terms of post-TURBT chemotherapy, this has been used for a while now. It is indicated for patients who have suspected or known low risk non-muscle invasive disease, and it can be used even just based on initial visual diagnosis, even before the histologic confirmation is made. And a meta-analysis done in 2016 showed that across all types of chemotherapy, whether it be mitomycin C, thiatipa, epirubicin, there was about a 14% absolute risk reduction of recurrence at 2 years. These medications are able to be instilled right after resection, but they are contraindicated if there is concern for perforation or if there's significant bleeding after the resection for concern of systemic uptake or spread outside of the bladder. And so people initially look to see if delaying 2 weeks would allow those patients to be eligible, but we found that there was decreased effectiveness for a delayed administration, and that giving the medication right away really provided the biggest benefit. And so that's generally the accepted pathway at this point. The reason that we anticipate that that's the case is it allows more immediate uptake of the medication into the bladder wall, as well as it kills any mobilized malignant cells that are floating around the bladder and prevents them from reimplanting into the wall. Over the past few years, a new medication, a new intravesical medication, gemcitabine, has developed some increased interest, and a study just 3 years ago showed that there was a 12% absolute risk reduction at 4 years when using gemcitabine after TURBT compared with saline alone. This has gained a lot of attention and increasing traction for a couple reasons. Largely, the side effect profile is decidedly less than mitomycin C, but also it's a fraction of a cost and may provide broader utilization based on that as well. In terms of intermediate risk non-muscle invasive bladder cancer, this is again the group that is somewhat of a, as the Europeans describe it, all tumors not meeting low or high risk criteria. And these are a mix of kind of the low grade, larger tumors or smaller high grade tumors. And they additionally are recommended to be treated with chemotherapy after TURBT, as well as induction intravesical treatment with either BCG or chemotherapy. If they get a complete response, then maintenance is indicated for a year to reduce recurrence and progression. If there is not complete response or no response at all, then a repeat induction would be indicated in an effort to control the disease that way. And then similarly, 5 years of surveillance, and then as indicated from there. As we move into high-risk non-muscle invasive bladder cancer, one of the most important factors in this path is to truly confirm that these are non-muscle invasive. Many of these tumors are very large or very aggressive, and as you can imagine, may have small portions that are muscle invasive. And the goal is to ensure that the appropriate diagnosis is made to give the appropriate treatment recommendations. For patients who have high-grade T1 or large multifocal TA, or that the initial resection was not visually complete, then a restaging TURBT is indicated to re-resect at the base of that tumor to confirm there is no evidence of muscle invasion. Once the non-muscle invasive designation is confirmed, then BCG is really the first-line treatment for these. It's got the longest standing track record. It has the best and most promising efficacy for recurrence and progression. If for some reason the patients are ineligible for that or they have previously failed it, then other intravesical chemotherapy options are available. But there's also always the consideration for radical cystectomy in these patients, particularly patients who have multiple high-risk features, whether it be concomitant high-grade TA and CIS, lymphovascular invasion, recurrent variant histology, or if they've recurred despite other bladder-sparing treatments. Another modality that is relatively new to this, the treatment of bladder cancer is the addition of blue light cystoscopy, which I find to be particularly helpful in high-risk patients, whether at the time of a restaging TURBT or during the course of surveillance, especially in patients with carcinoma in situ. This treatment option includes a installation of hexaminolevulinic acid, which is a chemical that induces photoactive porphyrins in the cancer tissues. And as you can see in this picture, the comparison of white light versus blue light, not only does it highlight the primary tumor, but it displays additional satellite lesions that may otherwise have been less obvious. This is really, like I said, beneficial in CIS patients where that type of disease is often very subtle and hard to identify when in small volumes. Studies have shown that this improves tumor detection for TA and T1 disease by about 25% over white light, as well as reduces recurrence and does reduce progression as well. Some of these things in terms of reduced progression, certainly could be through more complete resection of the tumor, identifying additional lesions, but may also be a representation that more high-risk features are identified and patients are maybe counseled to pursue a more aggressive treatment pathway, thereby reducing some of their risks of progression or worsening of their disease. All of this together has led the AUA to include blue light in their most recent guidelines as a should offer recommendation in an effort to increase detection and decrease recurrence of non-muscle invasive bladder cancer. So we're very happy that we have this to offer at Emory Urology. And, I find myself, and I'm sure Dr. Joshi does as well, using this very frequently in many patients with especially high-risk non-muscle invasive disease. Again, once the patients are confirmed to have a non-muscle invasive high-risk disease, then BCG treatment is indicated. Induction BCG follows the same 6 weekly installations path that has been described since the 1970s. If you're interested in some interesting history of medicine, you should look at how BCG was first started to be used, but that's a story for another time. And then the concept of maintenance was debated for an extensive period, no maintenance versus yes. And then once you say yes, how long? And so in 2000, a randomized control trial out of the SWOG group showed that 3 years of maintenance at the intervals of 3, 6, 12, 18, 24, 30, and 36 months with 3 installations at each time point showed an improvement in recurrence-free survival, as well as worsening-free survival, which is a composite endpoint of recurrence, progression to muscle invasive disease or radical cystectomy showed an improvement. And then 5-year overall survival did have a trend towards improvement, but didn't meet statistical significance. But all of this data combined led this to be a relatively widely accepted maintenance schedule and is included in both the NCCN and AUA guidelines for high-risk disease. While it is the most widely used, it is not universally accepted as the best, and multiple people have explored other options for a variety of reasons, whether it be access to BCG, patient toxicity, or other various causes. And initially, the Cueto group out of Spain looked at reduced density or a reduced amount of BCG to 1/3 dose and found good effectiveness. And so this was included in an EORTC randomized control trial that compared both decreased dose as well as shortened maintenance for BCG in patients with non-muscle invasive bladder cancer. It was interesting to note that, a surprisingly low number of patients or percentage of patients actually finished the full course as recommended, even in the reduced dose and reduced maintenance duration. A large number of those was due to recurrence of disease, and they were moved to a different treatment modality. About 7% stopped because of toxicity. That was the same across both the full dose and the reduced dose group. And then there was, 40% recurrence across this group, which fits with the data from BCG trials elsewhere. There was interestingly no difference in terms of progression to muscle invasive disease or differences in overall survival at 5 or 10 years. In terms of the recurrence and differences in administration and risk categories, when they initially designed and recruited this trial, there was not the current risk categories that we utilize, but they did utilize or evaluate those as the trial went on. And they found that in patients who have intermediate risk disease, if given a full dose of BCG, then there was no difference between 1 year and 3 years in terms of recurrence-free survival. If they got a reduced dose and had intermediate risk disease, then yes, 3 years was better. When they looked at the high-risk patients, for people who received full dose, the 3-year maintenance period was better for recurrence-free survival. And that is echoed in our current recommendations for 1 year of maintenance for intermediate risk patients and 3 years of maintenance for high-risk patients. Interestingly, this study did not include carcinoma in situ patients, and so that may show, even a more pronounced benefit for longer maintenance in those patients who have a high risk of recurrence and who respond very much better to BCG than other modalities. While 3 years of maintenance does sound ideal and it has the most data to back up those recommendations, there is the unfortunate reality that we currently live in a BCG shortage. Over the past many years, there's been steady decreases and difficulties in obtaining BCG, such to the point that within the past 1 to 2 years, Merck, who produces the majority of the US-based BCG, limited the allocation to specific centers, and not every practice is able to even access BCG. With this in mind, a group of large associations that manage, a combination of the AUA, SUO, BCAN, the Urology Care Foundation, and others, came together to put out some consensus guidance on how to manage this setting. And these were the guidance statements, which emphasizes no BCG for low-risk patients, to use intravesical chemotherapy for intermediate risk patients as the first line, and in many cases as the second line treatment. For patients who have high risk non-muscle invasive cancer, they should get full dose BCG if available, and if possible, maintenance for up to 1 year. If there's a shortage such to the point that you have to weigh the benefits of maintenance, they do recommend foregoing maintenance to prioritize induction for high risk BCG naive patients. And then if there's no BCG available, then induction chemotherapy and maintenance. Additionally, they make the appropriate point that for patients who are high risk, who are not willing to take on the oncologic risk or uncertainty that comes with some of these less established intravesical agents, that radical cystectomy can be offered and may be appropriate for those patients. We certainly hope that the BCG shortage is temporary and short-lived, and there are some indications that additional production facilities are moving towards coming online. But while that is optimistic, appropriately, many groups are looking at alternative means to utilize the resources that we have available to achieve comparable outcomes. And so some of the most recent data within the past year or two is one study is the Nimbus trial out of Europe that looked at reduced number of BCG installations for high-risk patients. This induction pathway was once a week at 1, 2, and 6 weeks, and then maintenance at 3, 6, and 12 months on the first and third week. They compared this with the standard formulation, which was the once a week for 6 weeks, and then maintenance for 1 year at 3, 6, and 12 months with once a week for 3 weeks, which is somewhat more of a standard at this point. Unfortunately, they found that there was a significant reduction in recurrence-free survival in the reduced formulation arm compared with the standard. And so, this does emphasize that this reduction of BCG installations is not quite as effective, and so maybe look towards an alternative form. With that in mind, the Memorial Sloan Kettering has looked at options for repeat induction and no maintenance. They recently published this paper looking at essentially 2 sequential BCG induction courses, a 6-week weekly installations followed by a cysto and potentially TUR, followed immediately by another 6 weeks. This did show a good response, 91% complete response rate at 6 months and 85% at 2 years, although this is still relatively early data. Fortunately, most patients were able to tolerate the complete 12 treatments, but without a comparison arm, it's a little hard to evaluate this, and certainly more information needs to be evaluated. And then lastly, there's an ongoing trial that's recruiting patients currently that's looking at a comparison of both a novel BCG strain, the Tokyo strain, versus the current Tice strain, as well as potentially intradermal priming, where BCG is injected into the skin prior to the intravesical therapy in an effort to prep the immune system for a more robust response. And this kind of harkens back to some of the original concepts that patients who had BCG or tuberculosis infections were more responsive to some of these treatments. And so that's certainly an interesting concept, and hopefully will show promise. Thank you all for your time. I'll turn it over to Dr. Joshi to carry on from here, and have a nice day.
All right. Hello, everyone. Let me share my screen. All right. Javier, can we see this?
We can.
Yes, yes,
Okay.
we can.
All right, great. So thank you everyone for attending. My name is Shreyas Joshi. I'm an assistant professor in the Department of Urology, and I am also the director of the bladder cancer program here in the Department of Urology. And I'm going to take over from where Dr. Browne left off and talk about that space between the failure of BCG therapy in patients with high-risk bladder cancer and cystectomy, because that's obviously where a lot of our effort goes into trying to salvage bladders. And so this is, basically how we use the terminology salvage therapies for this BCG unresponsive, specifically non-muscle invasive bladder cancer. So hopefully I can give you a good landscape and leave some time at the end to discuss. I have no specific disclosures related to this. So what we'll talk about, kind of the agenda here, is the landscape of salvage therapies, including intravesical therapies, followed by systemic therapies, of which there really is only one currently approved. Important trials, especially those that we're conducting here through the Department of Urology and Winship, the continued importance of radical cystectomy in this group, and also obviously want to touch on the importance of palliative care and palliation in this very complex group of patients. Just taking a snapshot at what exactly is available for patients who are no longer responding to BCG and continue to have high-grade bladder cancer. There's all sorts of things. Many of these are in the pipeline or currently getting studied. Some have already, shown some efficacy. Some have not. And just taking, for example, under the targeted therapy that's been Vincinium, just 2 days ago, the FDA refused to approve that in this space. So there's a lot of moving parts here. Many of these are intravesical, going into the bladder. Some of these are actual IV immunotherapies. Some are targeted, some are gene therapy. And so a lot of different work going on in this space. But, unfortunately, I regret to say that despite all of this, very intense work, we still don't have excellent data, nor do we have excellent treatment options for these patients as they progress through their BCG treatments. And so hopefully I can give you a sense of what we do have available and what appears to be working. But before we get into that, let's stop and say, what exactly are we talking about between BCG and cystectomy? Who are those patients that are BCG, what we call unresponsive? This is an important kind of nuance, because before a few years ago, there was actually no accepted definition for what this group of patients, or who this group of patients should be. There were multiple terms such as BCG failure, BCG refractory, BCG relapsing. They all had very different definitions in terms of when their cancer came back. And unfortunately, some of the early trials had to just rely on whatever definition the researchers were willing to use at the time, and continued to kind of follow their trials after that. So the community came together and decided that if more drugs are coming into this space, we should definitely try and make a standardized definition. And the FDA was able to step in as well and help give some guidance so as to standardize the patients that are in this space. So we now call adequate BCG as the 5+2 rule. That means that, as you know, the induction course of BCG is usually 6 doses. The patient needs to receive 5 of those 6 doses. And then if they respond to that, they will get maintenance BCG, of which they need to receive 2 of the 3. If after that initial induction, they continue to have some high-grade disease, the standard of care is to give them a second induction course of 6 doses. And they need to get at least 2 of those second doses. So either way, they need to get 2 additional doses, 5+2, within 6 months of initial therapy initiation. And that is, quote unquote, adequate BCG now. So what is BCG unresponsive? Well, they received adequate BCG, but now they have persistent or new high-grade T1, so that's lamina propria invasion at the first evaluation, so early on within 3 months. Or if they have recurrent high-grade disease within 6 months of completion, or if they have persistent or recurrent CIS with or without any other papillary lesions within 12 months. And the reason being 12 months, they've extended that time frame, is CIS is a very, very dangerous lesion. It's a flat carcinoma in situ, but it can, it can metastasize in and of itself, but it very quickly, just in the blink of an eye, can turn into some more invasive disease, turn into muscle invasive disease as well. So this is considered a high risk lesion. Unfortunately, we see a lot of that here at Emory, but that is something we consider BCG unresponsive as well within 1 year. So for those BCG unresponsive patients, there's different therapies that we've talked about. Let's talk about the intravesical salvage first. What does that mean? Obviously, it means that we're going to be putting a catheter into these patients' bladders, just like we did the BCG, and instill the drug or the active medication directly into the patient's bladder. And in order to determine the efficacy of these, it's important to kind of keep a baseline comparator in our mind. And most of us use the BCG data, right, from the initial SWOG study, that for patients receiving maintenance BCG, so those who are able to get through about 3 years from induction through maintenance, their 5-year recurrence-free survival is about 60%. So not great, but not too bad in the realm of high-risk cancer treatments. I went ahead and compiled kind of some of the best evidence for the different intravesical chemotherapy regimens and their actual recurrence-free survival outcomes. Now, none of these have overall survival data, and so we just have to grapple with that understanding that we're really just fighting with recurrences and progression here. But because bladder cancer is so aggressive, progression is oftentimes associated with early death, and so recurrence and progression are important endpoints for bladder cancer. So starting up at the top, mitomycin C monotherapy following BCG failure. Again, notice that terminology, failure, not unresponsive, because these were early studies. Was 20% at 3 years. Valrubicin, which is actually FDA approved for BCG unresponsive disease, is 21% at 6 months. That actually drops to about 12% at 1 year or longer. So that's unfortunately not a great drug. We don't use it at all. I don't even think we have it available here to use. Docetaxel monotherapy was much better, 40% recurrence-free survival at 1 year and 25% at 3 years. And then gemcitabine monotherapy was also quite strong, 28% and 21% at 2 years. And that's why people started kind of thinking, okay, combination intravesical chemotherapies might have a complementary role and improve the cytotoxic effect on cancerous cells. And so one of the first combinations tried was gemcitabine with mitomycin, and that was pretty promising. Almost a 50% 1 year disease-free survival and 38% at 2 years. Now that's great. I mean, that compared, if you look up, compared to the rest of them, that's really strong. The unfortunate thing about this is that mitomycin is not a well-tolerated drug in the bladder. Unfortunately, it can cause quite a bit of chemical cystitis, and especially for these longer-term regimens where you get 6 induction course doses followed by monthly maintenance doses. Some patients will many patients will fall off of the treatment regimen and unfortunately not get their full treatment that makes this effective. Which is why an increasingly preferred approach is the combination of gemcitabine and docetaxel in the bladder. And this is actually something that I advocate for and use almost exclusively here at Emory, because it's extremely well tolerated, much better tolerated than even BCG for these patients. The way we do it is a little bit more taxing, which is you have to put gemcitabine in the bladder for an hour, then drain it, then docetaxel in the bladder for an hour, then drain it. And the same sort of induction and maintenance schedule as the other chemotherapy agents, which is 1 time per week for 6 weeks. And then I usually take the patient to the operating room, do some biopsies, make sure their disease has not recurred or progressed in any meaningful way. Followed by, if they're responding, maintenance once a month for a couple of years and doing a cystoscopy and cytology every few months. The data is pretty promising. The Johns Hopkins cohort, they'd been doing this for a few years when they published this in 2019, showed that disease-free survival of about 50% at 1 year. That's probably one of the best that we've seen, and about 30% at 2 years. And of those who are responding, many of them will continue to respond through maintenance therapy. And so because of the side effect profile, which is very low, and the pretty good efficacy, we've been offering this to most of our patients in this salvage setting here at Emory. So moving away from the salvage intravesical chemotherapies, let's talk about what's FDA approved in the systemic therapy arena for non-muscle invasive bladder cancer that has not responded to BCG. And basically, this is an easy topic because there's only one drug out there, pembrolizumab, that's been approved and that can be used here. And that was based on this trial that was actually been running for the last few years, Keynote 057, that was recently had finalized data published. This was a single arm phase 2 study with systemic pembrolizumab. Cohort A was the important cohort here because CIS was really the treatment target. Patients received pembrolizumab and then, routine evaluation cystoscopically with occasional biopsies. And the data was just published in the Lancet in July, and it is what we already knew, but it's interesting to see that the complete response at 3 months was 41%, which is not bad. But if you follow that out, only 18 patients, so that's 18 divided by 96, that's about 19% of the entire cohort continue to have a CR at 12 months. Not great. If you look at this forest plot on the bottom, you see all the complete responses in the red triangles at the 3-month mark, and they very quickly start falling off with only a handful of continued responses beyond a year at the top of that graph. Now, of course, this is a high-risk disease that we'll take whatever inch we can get, but remember that everything has its downsides, and including the treatment toxicity of pembrolizumab. For any medical oncologist viewing this and who have experience giving IO therapies, most patients will tolerate it extraordinarily well, but some will have some serious issues. Up to 13% of patients in this trial had grade 3 or 4 toxicity, and 54% or 53% had grade 1 and 2 toxicities. So if the patient does have bad toxicity, it can be difficult to manage, and hopefully they wouldn't, but it is something to very much keep in mind, especially given the very, very low toxicities of the intravesical therapies, except for the fact that obviously intravesical therapies, you have to put a catheter in repeatedly, they can get UTIs, hematuria, things from that. And so it's a discussion that has to be had with the patient regarding their values and goals of quality from treatment. So that's all we have for known systemic therapies that have good responsiveness. So we next venture into clinical trials, which is, I think, the most important thing to talk about here, and is part of our guidelines as to something we should be discussing with patients. Just taking a snapshot, just from a few years ago, there's a lot of trials. That probably this chart is probably tripled almost in terms of how many types of trials are going on in the BCG unresponsive space. I find intravesical gene therapy to be particularly interesting. There are 2 specific ones that use a viral vector for gene transfer using an oncolytic adenovirus. One of them is to transfer a gene for an interferon protein, and that is now trademarked as Instilladrin. I highlight this one because Emory was one of the top accruers for this trial and is responsible for demonstrating the efficacy. And then a second trial that we just opened up that delivers a gene for GM-CSF, which is basically targeting cancer cells through a defective retinoblastoma pathway. So for the first one, for Instilladrin, that interferon gene transfer, the way this works is you put a catheter in, you instill the viral particles into the bladder. The viral particles infect cancer cells with the plasmid DNA. Which then uses, as we expect, the cell to produce the interferon protein, which then kills the cells from both within and from without through a variety of mechanisms. It's interesting that, there was a pretty good effectiveness at 3 months. The CR was 55%, more or less, and that's quite dramatic, in terms of that's a big improvement, another 5% improvement on some of the other intravesical therapies. Now, the longer term data is still maturing, but I think it's important to note that, if you know anything about urologists in the country, if you look at this author list, we really had good buy-in from literally every corner of this country in terms of involving patients in this. And so I feel like there is a good distribution and diversity of patients and good outcomes. So this is something to be looking forward to. I think the company is still trying to get FDA approval for this, but hopefully soon. We just recently opened at Emory a phase 3 trial evaluating the efficacy of the CG0070, which is that GM-CSF delivery via the adenoviral vector which we're very excited for because the early phase 2 data demonstrated about a 46% CR at 12 months, and it has a very good safety and tolerability profile. So looking forward to enrolling many patients on this here at Emory in the near future. Other clinical trials we have open here at Emory are such that they're combinations of intravesical and systemic therapy, such as a Merck trial we have that combines BCG with or without pembrolizumab. Also, there's an oral agent that's experimental from Bristol Myers Squibb. And this is a little bit more of a complex trial, but there's 4 arms, either using immunotherapy with nivolumab or nivolumab plus BCG, or nivo plus the drug, that experimental oral drug, or nivo plus BCG plus experimental oral drug. So we're really trying to nail down whether or not there's a more effective multi-dimensional approach to treating these. And then another thing that I'm very interested and excited about, if we can really find the right patients for it, are mutation-targeted therapies. Janssen already has an FDA-approved drug, erdafitinib, that targets other diseases with FGFR mutations. And so we are sequencing patients after their TURBTs who are BCG unresponsive to look for FGFR mutations or fusions. And if so, they would be eligible to get this oral agent that might have some real effectiveness in terms of blocking recurrences or progression. But let's not forget that the standard of care for BCG unresponsive disease is still radical cystectomy, and every conversation with the patient should begin with this sobering fact. Also note that bladder preservation is always ideal. And that's why we are trying to do all these different studies and give out these salvage options. But chemoradiation is not part of that for patients with non-muscle invasive disease, unless for palliative reasons. And that's important to note because patients will hear about radiation options, and the only known effective way to use radiation is for muscle invasive disease. And so it unfortunately is not an option here yet. And the reason that cystectomy is still so important is, this is data from a little bit over a decade ago, but is sobering and is still the data that most of us in the field refer to when we think about when we should perform a radical cystectomy for patients with disease beyond BCG. Look at these Kaplan-Meier curves for early cystectomy versus delayed cystectomy, and then the adjusted hazard ratio for cancer-specific death for deferred cystectomy is 5.1. It's quite dramatic for patients who have to get their cystectomy delayed, or if we're trying different things. Now, given that this paper was published, over a decade ago, we have a lot of more effective treatments for sure. But those more effective treatments are, looking at, maybe 5% or 10% more patients will have a complete response. It's not effective enough that we can forego talking about early cystectomies in these patients, removing the diseased bladder and potentially lymph nodes, and giving them a longer and potentially much better quality of life as well. And, I would be remiss to not talk about the fact that, palliation and palliative care are always appropriate options in this patient population. We've set up, and anyone who does this care must have a multidisciplinary team that helps patients make the best decisions. And I've been lucky to be able to help coordinate the services with medical oncology, supportive oncology here at Winship, which also has the palliative component, nutrition, rehabilitation services, and something that we've recently set up here, which is a bladder cancer peer support group, which is very important, I believe. So in summary, there is a standard definition now for BCG unresponsive non-muscle invasive bladder cancer. So that failure of the 5+2 BCG, and that's when we know we have to start thinking about how are we going to do what we can do to spare the bladder. High risk non-muscle invasive bladder cancer that's not responding to BCG is aggressive, and it just has few effective treatments, unfortunately. And we have to be realistic with patients about what those treatments are, what the side effects are, and the likelihood that they may need cystectomy. Options available for BCG unresponsive disease, in my mind, the way I kind of counsel patients are, always talk about the need for, and that data that I just presented for early radical cystectomy. if they are willing to kind of play with fire a little bit, and know that there's other options out there, but they may not be effective and we may lose our opportunity, then we start talking about salvage intravesical chemotherapies. I use gemcitabine and docetaxel. Obviously, we need to talk about the FDA-approved pembrolizumab salvage immunotherapy. I talk about clinical trials. We have multiple, as I talked about, open here, including the intravesical gene therapies, the combination intravesical and systemic therapies, and then the gene mutation targeting. And thankfully, the study sponsors for the gene mutation targeting pay for the genomic analysis of those tumors, and so that makes that easier. And then, of course, getting our supportive team involved, including palliative care. And if palliative care for older, sicker patients is the appropriate next move, then we can, get them into immunotherapy treatment or something of that nature in order to just kind of keep their disease at bay while their other medical problems kind of manifest. And never forget that early cystectomy is better than a too late cystectomy. So with that, I'll thank you. Here's my email address. I'm always happy to chat about any complex patients or take any, patients that might need some more discussion about salvage therapies or attempts at bladder preservation here at Emory. And we have the setup to do this well, and hopefully we can have good patient outcomes. So thank you very much. Thanks, Dr. Browne, for setting this up at the beginning as well. And I'll pass it back to you, Javi and Julie.
Thank you, Dr. Joshi, for a wonderful presentation. A couple of follow-up questions. You went through several of the ongoing and current clinical trials that we are having here at Winship. How would a oncologist in the community or referring physician in the community refer their patients to be considered for one of these trials, or at what point should they talk to you about that?
Yeah, I think Winship, generally speaking, has a proper kind of referral mechanism. But that being said, I'm always more than happy to just directly field questions through email or through direct messages through Winship in order to connect with any referring provider and just get patients seen ASAP. Sometimes it means that we need to kind of determine whether they need to be seen by medical oncology first or us, but generally speaking, for bladder cancer, we as urologists end up acting as the gatekeepers, only because even if they were already metastatic or needed something else, sometimes they will still need local symptom control, and we still need to be involved. And so I think it's always appropriate to come through us as the urologists. Email me, email Dr. Narayan, email Dr. Browne, and we will be happy to get them in.
Wonderful. And then Dr. Browne covered and touched on this earlier in his presentation, but wanted to ask you if you could reiterate a little bit about what we're doing here at Emory and Winship about the BCG shortage.
Yeah, so I think Dr. Browne, he covered the kind of different strategies. And at Emory, we've been a little bit lucky in that we've had a more stable BCG supply than a lot of community practices. For that reason, we have been able to continue full dose induction BCG courses for all patients with newly diagnosed high-risk bladder cancer. We stopped giving more than 1 year of maintenance starting in around 2019 because of the concern for the supply issues. Recently, we've kind of checked our stock and we've been doing very well. And so we are now continuing with 3 years of maintenance for all patients who continue to respond. But we are doing continued split dosing for that, so half dosing, which there's plenty of evidence that down to 1/3 dosing is actually just as effective. So that way we can make what we have last even longer and give people the longer duration, which appears to have a stronger effect on prevention of recurrence and progression. So here at Emory, we have a stable supply, thankfully. We're giving induction and 3 years of maintenance, and hopefully that will last, fingers crossed.
Absolutely. And just one final question, again, for our community of oncologists and primary care out there, at what point should they consider, referring their patient?
Yeah, I think, most community urologists, oncologists will understand the need and when to give BCG. And I think that after that first induction course of BCG, if the disease just doesn't seem to be responding the way that we are hoping, and there isn't a complete clearance in the bladder, I think starting at that point, moving forward, it is absolutely appropriate to go ahead and send the patient our way to have a second opinion about what their options are, because obviously local providers are more than capable of giving intravesical chemotherapies and all of that stuff. But I think it's important to have an early discussion with patients about radical cystectomy as well as the various clinical trials that we have in the space. So after an induction course of BCG, if you have pretty significant residual disease, I think it's always appropriate at that point to have them sent over, chat about it. Most of the time I talk to these patients and they still continue getting care locally until their disease progresses any further. But that way they can contextualize everything, have it in the back of their mind about when things need to start progressing.
Wonderful. Well, thank you so much, Dr. Joshi, for a fantastic presentation. To our audience, I just wanted to let you know that a recording of this will be made available on the Winship website. Thank you all. It does not appear that we have any further questions. So just once again, my appreciation to Dr. Browne and Dr. Joshi for joining us today. And thank you very much. Have a wonderful day.